of obesity. And also the cost of obesity, the treatment of it, and the side effects of being obese and the associated medical problems, diagnoses, and complications is one of the most expensive portions of the healthcare budget in this country, and it's going up. And you can see the average medical cost for people who have obesity is more than $1,000 more than those who are of a normal weight. So the way we think of obesity is, it's not the best way to describe it, but it's a good measure. And that's the BMI, so body mass index. And basically it's a simple calculation. It takes your weight in kilograms, divides it by your height squared in meters, and we come up with a BMI measurement. And it's good for a majority of people, not so great if you're like a star athlete or something like that, because it the muscle mass kind of throws off the numbers. But it's usually relatively accurate for getting a baseline idea of what your overall fitness and health is related to obesity. So when we think about obesity and people who qualify for surgery, the classic definition was people who have class 2 obesity, which is a BMI greater than 35. And you would qualify for surgery if you had a obesity-related comorbidity. So those are things such as high blood pressure, diabetes, high cholesterol, sleep apnea are usually the big 4. And then if your BMI is 40 or higher, you don't need those other comorbidities to qualify for bariatric surgery. Now, there were recent publications and recommendations by a couple of surgical societies to decrease the BMI limit for qualifying for bariatric surgery. So the new recommendations are class 1 obesity if you have a medical diagnosis related to it. It will obviously take some time for insurances to come around and accept that and cover the services for that. But those are kind of the new recommendations coming out, and we're hoping that insurance carriers will follow along with that in the upcoming years. So why is obesity bad? We talk a lot about weight and fat, and for some people, just those words have a bad connotation to them. There's a bad meaning behind it. And that's because surprisingly, we didn't consider obesity or morbid obesity to be an actual medical diagnosis until the most recent decade, until within the past 10 years, which is kind of mind-boggling when you think about it. So the idea of being centrally obese, having an accumulation of what we call dysfunctional adipose tissue, dysfunctional fat tissue, which results in the production of all these inflammatory cytokines, these reactive oxygen items that can result in cardiometabolic issues. It dysregulates the way you metabolize things. It causes cardiovascular problems. So the way that the fat is functioning and causing a metabolic effect is not helpful for your health. There's all these other things that obesity is related with: elevated levels of CRP, which is a reactive protein. There's numerous other markers of inflammation that result from obesity. And that's why it results in other diseases like cardiovascular disease, hypertension, hyperlipidemia. And that was the next slide, mentions the high triglycerides, dyslipidemia, glucose intolerance is changed, and it affects the way your body processes things. So all these kind of different enzymes and hormones are affected negatively. So what does that all mean? So as obesity and obesity-related diseases gets worse, we're also seeing an increase in other medical problems, the diabetes, the kidney disease, the sleep apnea. So if you go to your doctor and they find that your blood sugar is markedly elevated, your A1C is say 8, that's a diagnosis of diabetes. Oftentimes the conversation goes straight to, well, you need to be on medications. But the question is that the right thing? Did they get your weight at that time of the office visit? Because the diabetes may be a problem, but it might be secondary to being obese or having morbid obesity for the reasons that we just talked about. So obesity can can be a result of multiple different factors. It's not just a simple calories in and calories out. Medications can have an effect on obesity. Some medications cause weight gain. Endocrine disorders, particularly hypothyroidism, can result in weight gain. Your genetics plays a huge role. It's not all about calories in and out. You can do a right diet, but still be overweight and obese. And that doesn't mean that you're unhealthy. It just means that's how your genetics built you, but you're still at risk for having some of these other medical problems that we'll talk about, even if you're eating right. The environment that you grow up, culturally, there's certain foods that are more prone that when you eat them to become obese. And then there's the psychological factors that come with obesity too. And as I mentioned beforehand, being obese results in all these inflammatory changes to your nervous system, the way your cells produce enzymes and hormones, and that's why they cause all these problems. So what are some of the bad things about obesity? So people with a BMI greater than 40 are 2 to 3 times more likely to die than normal weight individuals over a span of 14 years. So the heavier you are, the higher chance that you're cutting off years of your life and potentially quality years of your life too. And that's why I think bariatric surgery and metabolic surgery is so important, because it's currently the most, not aggressive, I don't like the word aggressive, it's the most effective and durable form of weight loss treatment out there. And it has the highest effect on improving overall length of life and quality of life. So we talked about a couple of these things already as far as obesity risk and consequences, but I like to kind of expand about it so you can kind of see what I'm talking about. So we talk about lung disease and heart disease. Well, those are kind of nebulous, ideas. But when you talk about specific things, breast cancer, colon cancer, esophageal cancer, all these are increased with obesity. Cirrhosis of the liver, fatty liver disease is becoming more prominent in today's society. You have a higher risk of blood clots, pulmonary embolisms, diabetes, we already mentioned, and blood pressure. All these things come along with obesity. And then there's some more of the social and everyday things that you don't really think of. So we talked about the medical problems. If you have some of these medical problems, if you're obese, you have a higher risk of having a complication from those medical problems. There's physical limitations. Your ability to actually do normal daily functions is limited. That can be an emotional burden. It can be stressful, can result in loss of self-esteem. As I mentioned beforehand, we didn't recognize obesity as a disease until recently. So there's been a lot of stigma and discrimination related to obesity. It's not really something to be ashamed of. It's something that should be treated. There may be some prejudice as far as being promoted with certain jobs. That's been seen in work environments and just in society in general. And then the increased economic cost, both personally and socially, as I mentioned, with the cost of medical care. So why is this the case? Why are we getting worse? So even though there's all this information about weight loss surgery and weight loss meds and endoscopic interventions, of the people who actually qualify for weight loss surgery, we're only treating about 1 to 2%. That is an extremely small number when you think of all the people who could qualify for some type of obesity treatment. And part of the reason is that some people don't know, they don't have access to the care, and our goal is to really expand our ability to treat patients and to expand the knowledge of the availability of surgical treatment and non-surgical treatment. But the way we eat today is completely different too, and that's part of the problem. So, 40 years ago, the way we were eating, portions were much smaller. Things weren't supersized. The way we eat, the way we function and work, we're always trying to eat on the run. So we're drinking larger portions, and that has ultimately led to higher calories, higher fat consumption, higher carbohydrate consumption, and all this leads to weight gain. So what are reasons to have weight loss surgery? Well, we've kind of gone through all the bad stuff. So what's the good stuff? You can improve your physical health. A lot of the people just come in and say, I want to be able to play with my kids, play with my grandkids. I can't, I get out of breath just getting up out of the chair. So improving your physical health. When you lose weight, you're able to do more. It improves your mental and emotional health as well. You have increased energy. You're able to decrease or eliminate a lot of your medications. You get rid of your comorbidities. The success rate of surgery for getting rid of some of these bad associated medical problems like blood pressure, diabetes is extremely high. For certain things, you can come off medications 50% of the time. For other things, depending on what surgery you get, it can be up to 80% of the time. Those are really high quality numbers. If you're just being treated with medication, you're on that medication typically for life. So it's pretty cool to have an option that can help you cure yourself of these other associated medical problems. We talked about length of life and quality of life being improved. And then, obviously some people just do it because they want to lose weight and look better. So, becoming a desired weight or size is also a reasonable option for you. So there was a study in 2004 that looking at long-term mortality, morbidity, and health. So it showed that people who had surgery for weight loss had lower number of general hospitalizations by almost half, fewer hospital days, length of stay in the hospital, and fewer physician visits because of overall being healthier. And it also decreased the overall healthcare cost as well. We also talk about reduction in mortality, less chance of dying. So 29% of death by the Swedish obesity study, which is a really big study many years ago. And then there is this other study by Adams, reducing mortality by 40%, 60 decrease in cancer death, and 92% decrease in death from diabetes. Those are all outstanding numbers. So weight loss surgery does go a long way and has some pretty good outcomes. And this is just more information about that, just more good numbers supported by the data that's available. And this is some comparison, which I think is useful because there's a lot of information about weight loss medications, and we'll get into some more of those at the later point in the presentation. But this is a good side-by-side comparing surgery versus some of those medical therapies. So this first study, Ikramudin in JAMA, the journal, showed that gastric bypass people lost typically a total body weight percentage of 26%. That's a pretty good number compared to intensive medical therapy, diet, exercise, medications, only about 7%. So even with medications, this study showed that you can lose almost 3 times as much weight or more with weight loss surgery. And we see this with some of the other studies that were published in the New England Journal of Medicine, gastric bypass, sleeve gastrectomy, and even lap band, which currently has kind of fallen out of favor. Those numbers show much higher success rates with surgery compared to just medical therapy. And again, improvement of comorbidities. We talk about asthma, high blood pressure, diabetes, sleep apnea, and even GERD in some instances. There's improvement and resolution in a majority of cases. What about the safety? A lot of people always come in and they're concerned, well, I don't want to get surgery because I think it's too aggressive and too risky. So the way I kind of like to put it in a box and think about is that all these little blue boxes on the left are all studies about the safety of bariatrics. And then from the pink box over, it talks about hernia risk, appendectomies, GI obstructions, cholecystectomies, gallbladder removals, heart catheterizations, getting stents in, and it shows the risk of mortality with these operations. So this study was the LABS consortium, the longitudinal assessment of bariatric surgery, looked into the safety and rate of mortality related with bariatric surgery, which are all the blue bars on the left, compared to other common operations. And bariatric surgery was safer than hernia repair. Now you think about people getting hernia repairs all the time, and most people don't blink an eye about it, but the risk of getting a hernia repair is higher than bariatric surgery. So that kind of puts it in perspective for a lot of people when you kind of compare it to these other operations that are very common. And I love this study. So this one, the conclusion was that patients with a BMI less than 40, so in that range of 35 to 40, are more likely to get to a BMI of less than 30, so out of the obesity range, and also more likely to improve and get rid of your medical problems. The kicker was that if you have a BMI over than 50, so you're kind of in that really super morbid obese range, even if you get surgery, the outcomes are not as good as if you got surgery early on. So kind of the point of that is that early intervention makes a difference. So people think that, oh, my BMI is 38, 42, I don't need bariatric surgery. But as time goes on, the long-term chronic effects are cumulative. So the more you gain, the more weight you gain, the harder it is to lose the weight despite surgery. And you're already losing time that could have went towards putting those comorbidities into remission. So I like this graph because it kind of gives an idea of the overall effectiveness of all the treatment options that are out there. And I like to compare them in simple terms. So you have diet, exercise, medications. Think of these as like a skateboard. So they're effective to get you moving around, but it's not going to be super fast or durable. Then there's intraluminal devices, endoscopic therapy. So we're talking about endoscopies like gastric balloons or endoscopic tightening of the stomach. Think of these as like a bicycle. They're a little bit faster than a skateboard, but you're not going to be cruising down the highway on a bike. Then there was lap band. Lap band was very popular in the late 2000s, early 2010s. Kind of fallen out of favor now because it was purely a restrictive type of procedure. The only thing that we were doing was putting a foreign body in the abdomen and wrapping it around the top part of the stomach. So the issue with that is it resulted in a lot of reflux. And then people had issues with finding the sweet spot for how much fluid to put in the band. And it was very high maintenance. And then a lot of people end up having to take it out due to complications. So the lap band, although a little bit more effective than some of the other things we just talked about, not really the best option. So then we get into more of the general surgery options, which include sleeve gastrectomy, SG, Roux-en-Y gastric bypass, RYGB, SADE or one anastomosis duodenal switch, and duodenal switch. So those are kind of the order of aggressive, very durable operations that are surgical in nature, and they're very effective. The way I like to compare it is that 80–90% of people who get weight loss surgery end up maintaining some form of durable weight loss, and those are pretty good numbers. There's always a small percentage. I'm not saying surgery is perfect, because it's not. There's not a perfect solution for everybody, unfortunately. I wish that was the case. So there is a small portion of patients who have unexpected low weight loss or insufficient weight loss. But then you can also add to your surgery, you can add the medications, you can add the diet and exercise to complement it and try and get them down to a reasonable weight. But the majority of patients do quite well compared to if you just do diet and exercise, although that can be very successful in the short term. In the long term, 5–10 years out, I'd say 80–90% of people gain back most of their weight. So that kind of goes into why not just be aggressive with diet. This was a study from my fellowship at Duke that they did before I got there, that they set aside a patients to just do very aggressive medical management. And in the long term, that group of patients lost 240,000 pounds. But the flip side of that, in the long run, they gained more weight than they actually lost once they followed them out in the long term. So the verdict was diet alone is typically not successful for durable weight loss. And in the long run, you get no improvement in quality of life. And this kind of is the summary of that. Short-term obesity therapy doesn't typically result in long-term weight loss. Now, and I want to make a key distinction here. I think it's really important to specify what group of patients we're talking about. We're still talking about patients with class 2 obesity or morbid obesity. Yeah, for a short term, you can lose 5–10 BMI points, but in the long run, you're really going to need something more durable and more effective to really have substantial weight loss that's going to be beneficial. Then some people come in and say, oh, medications are all I need. And that may be the case, and for certain people, but we got to think about the patient population. I think medications are great. And there's some new medications out there, that are more effective than the ones in the past. Unfortunately, you need to stay on the medication for life, otherwise you're going to gain the weight back. So that's one aspect of it. The second aspect of it is having realistic expectations of how much weight you want to lose or need to lose. So some of these weight loss medications can help you lose anywhere between 10–15% of excess total body weight loss. But if your BMI is 50 or you're starting at a weight of 350–400 pounds, that's not going to get you out of the morbid obese range. Even if you maximize your medical therapy, you'll probably still be in the morbid obese range and still have areas to improve when improving your overall quality of life, length of life, and improving medical conditions. So they work up to a certain point. So you may not be able to sustain long-term weight loss with some patients. As I mentioned, you lose typically around 5–10% of your weight, but some of the newer ones, it's more around 15–20%, which are pretty good numbers. We're not only treating hunger, there's other things, there's metabolism at play. And that's why some of the newer medications are helpful, because we're affecting some of the pancreatic hormones. But some of the other medications don't affect the whole metabolism. And then medications are not risk-free. There are side effects. Some patients can't tolerate the medication. Some people have fast heart rate, palpitations, drowsiness, intolerance to the medication. So not only does surgery have risk, medications have risk too. So there still may be benefits that outweigh those risks, but again, depending on what a person or patient's individual BMI is, it may not be the most effective option. So what are some of the medications out there? Phentermine has been around for forever. It's a very cheap medication. It helps increase your energy, decreases fatigue, decreases cravings, helps you lose about 5–10% of that excess body weight. But there are certain circumstances where you shouldn't use it. And that's when you have uncontrolled high blood pressure. Well, a lot of people with obesity have high blood pressure, so that may not be a good reason to use phentermine. People with bad cardiac disease, it's not recommended. And then people who have glaucoma or hyperparathyroidism shouldn't use the medication. So there's reasons why some of these medications shouldn't be used. A newer one is a more long-term medication. It combines phentermine with topiramate called glucosamine. Works very similarly, has pretty good long-term weight loss, similar side effect profile, can be expensive if not covered by insurance. Contrave is another one. This one works a little bit differently. It helps make you feel fuller by working through a different mechanism. Helps you decrease snacking, coincides with treating depression because it actually is a depression medication as part of the formulation. But again, there's certain reasons and side effects that make it a little bit intolerable for certain patients. The big one is kind of this one, Saxenda and Wegovy. I didn't get to update my slide, but Wegovy is kind of one of the newer ones. It's like Saxenda. Saxenda is a daily injection. Wegovy is a weekly injection and a little bit more effective from the data. So this is one of the medications that affects one of the pancreatic enzymes, helps you decrease hunger, helps with your portion control, affects the way that insulin functions in the body, helps slow down emptying out of the stomach. So very helpful with diabetics, but also helpful for patients who are overweight because the weight loss is a little bit higher, 10 to 15% compared to some of the other medications, which is 5 to 10%. But again, certain circumstances where you shouldn't use it. People who have bad liver disease, people who have pancreatitis, and people who have a history of specific types of thyroid cancer. And there are side effects with the med, and you kind of titrate the dose to kind of figure out what proper dosage is appropriate for you, because the higher you go up, the chance of having some things like nausea or vomiting or low blood sugars or even heartburn can increase with the medication. But that's one. Wegovy is one of the more popular ones over the past 1 to 3 years. So then what about non-surgical options, the endoscopy stuff that I had briefly mentioned? So gastric balloons, some people may have heard of. These are not long-term solutions. They only stay in for 6 months. They're not FDA approved to stay in longer. Some may be up to 12 months, but they have to be taken out. So usually they're good for, I like to say the lady who's getting married and wants to lose a couple of quick pounds before the wedding. So it does have some good weight loss, 10 to 20% of extra weight loss. But once it's removed, you're removing that restriction that's created by filling the stomach up with this balloon-shaped item, because purely it's a restrictive type of thing. It fills up the stomach, so when you eat or drink, there's less space for you to fill up your stomach. So when you remove it, all the weight comes back. And then there's also plenty of side effects with it. Because you're filling up the stomach with this foreign body, a lot of patients have heartburn and reflux. It can erode in the stomach wall and then also become dislodged. Another popular one over the last few years is something called an endoscopic sleeve gastrectomy. Now, some of the quoted literature says that excess weight loss is 30 to 45%. And you're probably asking yourself, hey, that's pretty good compared to some of the other numbers we're looking at. And you're right. So basically what this procedure is, there's no incisions. It's all done through an endoscopy through the mouth when you're asleep. And what you do is we take this endoscope, special endoscope, and basically suture the wall of the stomach, the outer wall of the stomach, and cinch it tight together. So it's like creating a sleeve gastrectomy like you would normally do it surgically, but doing it from an endoscopic fashion. Unfortunately, the results are not as good as a standard sleeve gastrectomy. And that's because it's hard to suture up the whole length of the stomach. You can do most of it, but the top part is left open. And then another reason is that after about 3 or 4 years, some of those sutures can unravel and stretch out. So it's in the long term, we're finding that it's not the most durable solution, but it is a little bit more effective than some medications and diet and exercise alone. So I usually think it's a good option for patients who may have really bad medical problems. They're very high risk for surgical intervention. This is a good kind of non-operative way to help you lose weight that decreases your perioperative risk. So I think that's where this kind of fits into the overall algorithm. So why is surgery more effective? Why do we talk about this? And that's because of its metabolic effects. So what do I mean by that? So we talk about bariatrics in many ways. We talk about restriction. We talk about malabsorption, meaning that if we're bypassing part of the intestines, there's less absorption of the food and liquids that you eat or drink. And what I really mean by metabolic is that we're changing the hormones, the way that the hormones are sending signals to each other, the receptors that are available, and modulating insulin. So we're affecting your metabolism and changing it for the better. So we talked about who qualifies for surgery already, kind of the BMI ranges. Some of the things that are required for most bariatric programs are no substance abuse, being psychologically stable, because, after getting this big surgery, there are some emotional changes that sometimes happen, and we don't want to make sure you have any problems afterwards that may be uncovered preoperatively. Having a strong social support is always important. Having people who are your cheerleaders to support you along the way is always good too, because this is not the easy way out. It is tough sometimes. That goes into my next slide. So the operation alone is not the key to success. We are affecting metabolism. We're restricting the size of the stomach. We may be bypassing part of the intestines. We like to think of it as a tool, though. This is your way to get to where your goal is. But you got to be committed to lifelong changes, which can be difficult. And those changes include making sure you're eating and drinking the right things, avoiding any foods that may make you feel sick, increasing your protein, limiting carbohydrates. There are significant dietary changes that come along with it. It's not just the surgery. And we break it down into nutrition, physical activity, the surgery, and then overall wellness. So as far as the nutrition, it has to be a priority before and after surgery. So you don't just kind of work up the surgery focusing on what you need to do leading up to it. It's all about the after too, because that's how you maintain weight loss in the long run. So following the nutritional guidelines is essential for maximizing weight loss. Most bariatric programs, or all bariatric programs, have a dietitian or nutritionist that will work with patients to ensure that you're following the right steps and staying on point where you should be. I like this graph because it kind of shows long-term weight loss and with and without maintenance therapy, meaning that you're making sure you're staying on top of your nutrition. So the first kind of 5 months is diet and behavior modification. And then at the 5-month part, they split patients into patients who had continued teaching with diet and behaviors versus those who did not have any additional help. And it showed that the patients that continued to have help had continued maintenance of long-term weight loss as time went on. And those who didn't have any extra help kind of fell back on old behaviors and started gaining weight back again. So that's why it's important to maintain appropriate behaviors. And also, most bariatric programs encourage long-term follow-up. So it's not like you get surgery and you get sent on your way. We follow up with patients on an annual basis for the rest of their life to make sure we're helping them maintain appropriate weight loss. So some people have questions about what the diet's like initially. So in the long run, you can go back to eating normal food. It's just kind of focusing on lower carbs, higher protein, and lower volume because you have less space to fit the food in. Initially after surgery, because the tissue is sensitive and healing, we do liquids for 2 weeks, then typically blended or pureed soft foods for 2 weeks, and then you do solid foods at 4 weeks after surgery. Big things are getting in your fluids to avoid dehydration. And working slow at that because you have a new kind of point where you may get too full where you can get sick. So it's kind of finding that balance initially after surgery. 60 to 90 grams of protein daily, that's usually pretty easy for most people. Trying to avoid sugary foods and high caloric non-nutritionist foods like sodas. The carbonation's not good. You're not getting any good nutrition from that. It's basically calories that don't give you anything. We talked about protein already and some sugar and fat, so we'll just kind of keep moving along. We encourage you not to skip meals. Skipping meals kind of stalls your metabolism, and it's hard to eat a large meal when you have one of these surgery operations just because you have less space. So in order to meet your hydration and protein goals, it's important to kind of spread out your meals throughout the day to ensure that you're getting in adequate nutrition. Vitamins are required after bariatric surgery. The reason for that is because you're eating less calories, you're not getting all the micronutrients that you typically need when you're after bariatric surgery. So you do need to be on vitamins. Usually it's a multivitamin, some calcium and vitamin B12, and that usually satisfies that requirement. Our program uses an application on the phone called Baritastic. I think this is pretty cool. This is free to all our patients who are part of our program. And basically, excuse me, it's an app that you log in and you're tied specifically to our program. And what you can do is you can log in your food that you eat throughout the day, everything you eat or drink, and our dietitian can see a report of everything that you log into the system. So she can give you personalized information about what you're doing and how to improve what your behaviors are, how you're eating and drinking. There's also stuff about exercise and recipes. It's a pretty cool application. So there's things like this, not just for our program, but there's other applications that are available for patients that are great tools to help you with weight loss success. Physical activity is always important to stay active. And I always tell people, you don't have to be Superman or Superwoman. You don't have to work out an hour a day, 7 days a week. So just start off doing something small, 20 minutes a day, 3 days a week. Just do some walking. That counts. That's exercise. Physical therapy counts if your mobility is limited. You kind of you want to start establishing a behavior, make it a habit. And if you do it, then you can build upon it once you make it a habit. But you have to be realistic with your schedule because everybody's busy. I get it. So that's why I'm saying for people who are very busy, just start off doing it small, 10 minutes here or there. And then once you get into a habit, the more you're doing it, the more likely you're going to keep doing it. So some of the surgical options, the big three are the sleeve gastrectomy on the left, the room-wide gastric bypass in the center, and the more aggressive one, the duodenal switch or SADIE operation, single anastomosis duodenal ileal bypass, are the three that we do here at our program currently. So which one's right for people? So we consider a lot of things. It's not just patients come in and I say, or Dr. Ritter says, this is the one you're getting. We got to talk about it. We talk about why different surgeries are appropriate for certain patients. Because like I said in the very beginning of the talk, I wish there was one standard operation that works best for everybody, but there's not, unfortunately. So we kind of figure out which one's best for our individual patients. We consider the health problems, lifestyle goals, people's age, how much weight they want to lose. All these kind of things kind of go into making the decision on which one's right for that individual patient. And we decide that mutually. So I kind of talked about these procedures are being metabolic. Some of these procedures in the past were strictly restrictive or strictly malabsorptive, kind of moved away from that. So that's why I think bariatric surgery has some bad connotations, because you hear a lot about some complications that happened 40, 30 years ago. And the way we're doing surgery, the quality of the instruments, what we know, the data, surgery is a lot better now, a lot safer. So I think a lot of people have been scared by surgery because of that, when in reality, these days, it's quite safe. So for a sleeve gastrectomy, what we're doing is basically removing the outer portion of the stomach. We're removing about 60, 70% of the stomach and basically making it from a big pouch, like a big purse, and making it into a skinny pipe, a skinny tube that's shaped like a banana. So nothing's rerouted, nothing's inserted into the body. We just remove a portion of the stomach. So it reduces a lot of the receptors that are in the stomach when food and liquids go in. So you're less signals to the brain that say, feed me, I'm hungry. So we're reducing ghrelin, the presence of that hormone. There is the potential for heartburn, because when you take a big stomach that's like a big pouch and make it into a skinny pipe, there's less space. So when there's less space, pressure can be higher, and that sometimes forces things up the wrong direction. So some people can get heartburn. Usually it's controlled with medication though. And we talked about vitamins already. I'll talk about dumping with the gastric bypass. So gastric bypass has been around for forever. So we kind of consider this the gold standard to which we compare all operations these days. Nothing is removed, nothing's inserted, but we do reroute the intestines around. So for this one, we kind of create a pouch of stomach tissue at the top of the stomach, right below the esophagus, and then attach a piece of the intestines to that pouch. So food and liquids go down the esophagus into this pouch, and directly into this portion of the intestines. The big part of the stomach stays inside, doesn't get taken out, but it still produces gastric acid to break down food. Your liver, gallbladder produce bile. Your pancreas lives underneath the stomach, that produces digestive enzymes. So all these digestive juices are going down this other pathway. It meets the food and liquids from the top. It all combines and gets absorbed in the rest of the intestines. So that's why it's called a bypass. So your food and liquids are bypassing that small portion of the intestines and the larger part of the stomach. There is a risk with this one. You can have a risk of an ulcer formation at the top connection. That's usually increased in people who smoke or take NSAIDs regularly, NSAIDs being Motrin, Aleve, Advil, naproxen, that type of stuff. There is this thing called dumping syndrome. I usually don't like to describe that as a side effect or a complication, but really a side effect of bad behavior. So as you can see, when you eat or drink stuff, it goes pretty quickly into the intestines. So there is some absorption that starts pretty quickly. So if you eat something that's high in sugar or high in carbs, carbs break right down the sugar. So your body's getting a load of sugar pretty quickly, and it leads to a spike in your insulin, rapid spike in insulin, and a rapid drop in that as well. So rapid spikes with carbs and sugars, and rapid spikes in insulin creates this feeling of queasiness, abdominal pain, and then the late symptom of diarrhea. So it's kind of a side effect of not eating the right way that you should. Single anastomosis switch, or SADI, there's lots of acronyms for this. It's basically the easiest way to explain this one is it's a combination of both procedures. So we make a sleeve gastrectomy, just like I talked about in the first operation. And then we do a bypass right after the stomach, right after the muscle that stops at the end of the stomach. And it's a longer bypass compared to the standard gastric bypass. That's why it's the most, what I'd say, aggressive operation, but it's the most effective operation as well. Slightly higher risk in complications just because it is a little bit more involved. It's a longer operation. So typically reserved for people who have higher BMIs in the 50s, 60s, who have, numerous medications for those medical problems. So it's a more effective operation for those who need to lose more weight and are on multiple medications, who are trying to come off all those medications or at least reducing the dosages. A little bit higher risk of nutritional deficiencies with this one, just because of how much intestines are bypassed. Still pretty low in the long run, but vitamins are of utmost importance. So what are the outcomes? Outcomes are really good. So remember, if you think back when we talked at the very beginning, we were talking about diet and exercise and medications, about weight loss being around 10 to 15%, and then endoscopic therapies being around 30%, maybe. So then with these, we're talking over 50% of extra weight loss, how much extra weight that you have on that you can lose. So these are great numbers. So for the sleeve, majority is around 60% of excess weight loss. These are good numbers. For the bypass, a slight edge, more around 65%. And then for that SADI switch procedure, more around 80%. So these are really great numbers, very durable operations. There is a little bit of expected weight gain. So most people will lose weight over 1 to 2 years, get to their lowest weight, maybe gain, depending on what their starting weight was, maybe gain like 10 to 20 pounds and settle off there. And that's typical for most people because they kind of, it's like resetting the thermostat in your house. You're just resetting your thermostat in your body though. People who tend to gain weight are people who just kind of fall off the wagon and kind of stop following the appropriate behaviors. Sometimes, the stomach can stretch a little bit. It's never going to stretch to as big as it was initially. But sometimes that can lead to being able to eat or drink a little bit more. And there's lots of things we can do to help with that. That's when we add in medications or do an endoscopic procedure to tighten things up. But the most effective thing overall is going to be the initial surgery. So like I said, there are risks. They're very rare these days. And that's a good thing. Mortality is very low, as we mentioned in that previous graph. Some of the intraoperative risks are just like any other procedure: bleeding, injury to other structures around where we're working. People who are obese have a higher risk of clots, but we are very careful with giving people blood thinners around the operation time to decrease that risk. It's very rare, basically. Risk of anesthesia is the biggest one, just because people are a little bit higher risk, but all that's rare as well. Very rare to convert to an open operation. We're not really making big incisions anymore. This is all done laparoscopically or robotically, tiny incisions, stay in the hospital for 1 or 2 days, and then you go home. There's even some surgeries that are day in, day out, outpatient surgery. Talked about a couple of the risks. Just like any operation, we really try to do our best to prevent most of these, and most patients do very well. So then the backside of it is the commitment to a lifelong healthy living. So for our program, patients attend a seminar. We give them a packet that they fill out to give us more information about their health. We confirm insurance benefits. We arrange for those visits with the surgeon, the dietitian, the mental health provider, making sure your PCP is on board, making sure that you're ready for surgery. Once all that stuff's done, we do the surgery, and then we have that lifelong follow-up that we mentioned. So we're always there every step of the way, 2, 4 weeks, 3 months, 6 months, and then annually after surgery. So we're always there as a support system. We do a lot of additional support too, not just the visits. There's a monthly support group. We have a Facebook group where patients have access to each other to kind of go through things that work for them, what doesn't work for them, share recipes. We have the app that I talked about. We have access to our team and the follow-up yearly that I had mentioned. Long-term success is dependent on patients though. So we can do our best, but as long as you're doing the right things, you'll have good outcomes typically. So making sure people come to their regular appointments is of importance, compliance with diet and exercise, keeping up with the support groups, and having the family and friends support. That's a really big one. Some people, it's a big change in lifestyle, going from eating what you used to this whole new type of diet. So for some people, that's really tough. So having people who are there to kind of be your cheerleader and support you and eat with you, eat the same type of stuff, that's really cool. That goes a long way. It makes it a lot easier. So why should people do weight loss surgery? It's because it works. The data shows that it works. It's very successful. It's effective. We have good results for a majority of patients compared to simple diet, exercise, medications. Those things work up to a certain extent. But if you want the most effective thing, it's going to be surgery. And it's safe these days. Again, I want to say that some of the complications from surgery that happened 20 years ago don't really happen these days. When weight is lost, comorbidities improve. So it's really, whenever anybody is obese or has morbid obesity and they're diagnosed with high blood pressure or diabetes or high cholesterol or sleep apnea, I think the number one thing we should be treating is the weight and the obesity, not necessarily treating the side effects of the obesity. So a lot of the focus ends up being on the diabetes and treating that, and all that stuff should be treated at that time, but we're not treating the culprit. We're not treating the cause of all that, which is the obesity. Across a range of medical problems, 75 to 90% of them will improve or be completely resolved with surgery, which is fantastic numbers. And then long-term mortality is reduced. Longer length of life, higher quality length of life. So if people are interested in bariatric surgery, there's a couple of things to know. There is an accreditation and quality improvement program that monitors all bariatric programs. Our center is a comprehensive metabolic center. And then we also have recognition through different insurance carriers, and the big ones being Blue Cross, Cigna, and Optum. So we're a center of excellence and Blue Distinction Center for all three of these insurance carriers. That's all I had. I hope that was informational and helpful, and I hope everybody took something away from that. And I'm happy to answer any questions if people have them.
Yeah, please don't hesitate to take advantage of this time to ask Dr. Snow some questions. This was a great presentation, very informative. Well, I know it's kind of hard probably to answer this question. Which surgery do you, and I know it depends on each person's actual situation, but which one do you, which one do you do the most?
So our program, along with a lot of programs in the country, the sleeve is the most popular one, and people like that one because they feel like it's not as invasive. They're not rerouting the intestines around. It has a little bit lower risk profile compared to some of the other procedures. A little bit quicker time on the operating room table. So there's lots of benefits of that one. The caveat to that is compared to some of the other ones, it's not the best option as far as overall weight loss. You can still get great results, and everybody responds differently. I've had people get a sleeve, depending on what their starting weight is, and lose 170 pounds. I've had people lose 80 pounds. It's different, and a lot of it depends on where the starting weight is and BMI. So you can't compare one patient, the numbers, to another patient unless you know the starting weight or the starting BMI. So a lot of patients come in and will say, my cousin got the sleeve at this place and lost 100 pounds, and I know this other lady who got the sleeve and she only lost 40 pounds. And it's like, well, it all kind of depends on a lot of factors that you may not know about. But sleeve is the most common in the country. It's the most common that we do. But I think you don't want to do a sleeve if you have really bad heartburn or reflux, because that can make it worse. And there's a lot of studies coming out showing esophagitis and even Barrett's esophagus, which is even worsening cell changes, metaplasia, dysplasia of the lower lining of the esophagus from bad reflux. So if you're at risk for that, that's not a good option. The better option would be a gastric bypass, because a gastric bypass is actually a low pressure system because we're bypassing the muscle at the end of the stomach. So we're avoiding that. So we're creating a low pressure system. The caveat to that, you don't want to do a bypass in somebody who's who smokes, because the risk of that ulcer is higher. We tell everybody to stop smoking because the risks are high with any of these operations. So we're trying to do what's right for you as a patient because it's safe, but we also don't want you to have a problem afterwards. But smoking is really bad for bypasses because it results in ulcer formation, much higher risk And then people who take NSAID medications, those ibuprofen, Aleve, Advil, higher risk of developing an ulcer with a bypass compared with a sleeve gastrectomy. So these are the things we have to factor in. And sometimes people don't have just one of these things. They have all of them. So we have to kind of weigh the risk and benefits of which one's right. And then I do the SADI. There's not everybody's trained in doing the SADI or doing a switch procedure. I think it's a good option for more super morbid obese patients, kind of that 50 and higher BMI range, especially if you have multiple medical problems. Because if you want an effective and durable option, you may not get the weight loss that you want with a sleeve compared to that option.
I'm glad you mentioned. Oh, go. I was just going to say, I'm glad you mentioned about the acid reflux, because I have acid reflux. So I know several people that I worked with when I was working at the hospital had the sleeve procedure and seemed to have done really well from it.
Yeah. So weight loss can, as you lose weight, that decreases your intra-abdominal pressure, and that can help reflux. So sleeves can still help reflux. But the way I look at it is, if you have reflux symptoms and you're still having them despite being on medication regularly and avoiding the trigger foods that set it off, the sleeve may not be the best option.
Okay.
I have a question. What happens to the excess fat or flesh?
So depending on the age, everybody's skin and tissue responds a little bit differently. So the younger you are, it does kind of tighten up a little bit better with exercise after you lose the weight. Some people do have a fair amount of excess skin and subcutaneous tissue. Now, what I always tell people, if that happens, that's the lesser of two evils, because that's not going to, excess tissue's not going to cause the blood pressure or the diabetes. It's the extra obesity that's going to do it. But you can have some side effects from excess skin and tissue. You can get rashes that can get infected, and that's not enjoyable. So when it gets like that, the option is really kind of plastic surgery, doing excess skin and tissue removal to tighten that area up. Now, that doesn't happen to everybody. I'd say it's the lower percentage of patients compared to the majority.
Okay. Thank you.
You're welcome.
I wondered about that too.
Yeah, so I wouldn't say that, it's probably only about 10 to 20% of our long-term patients who ask about, plastic surgery and getting that excess tissue removed. Unfortunately, it is a plastic surgery operation. So a lot of times insurances don't cover it unless there's good documentation of chronic infections and chronic rashes. So that is a downside of it. But like I said, it's the lesser of two evils when it comes to obesity or having excess skin. But again, a majority of people I find don't have it where it's that bad.
You ever had a case where, there's a person who needs the surgery, but the insurance won't cover it?
Yeah, that's an unfortunate thing, because there are certain procedures that insurance hasn't recognized yet, or they're not following the guidelines that have been put out by the national societies. So sometimes I think a SADI may be better for a patient than a sleeve, but they don't approve the SADI because they, for some reason, haven't followed the new guidelines that that's an appropriate operation for these procedures. Sorry, 1 second. Or some people just don't have bariatric coverage on their insurance, and that's the tough part, because patients who meet these criteria from a medical standpoint should get surgery if they want to help their medical problems, but we're limited if it's not included on the insurance. So oftentimes, depending on the employer, there has to be a bariatric rider on the insurance to be included. So that's why we always verify benefits before people start the program, because we don't want people to go through this whole process and then find out at the very end that they can't do it. That would be kind of a mean thing to do. So we always find out up front. If it's not covered, then paying out of pocket is an option. That's not an option for a lot of people, though, unfortunately. But then it comes down to what are other options. The endoscopic procedures are available. Those are not covered procedures, though, even if you have insurance, but they're cheaper than surgery. And then there's the weight loss medications doing that. So those are kind of the other options. Believe me, we're not happy when patients don't have the coverage. We want to try and help out everybody, and we fight for people, but if it's not included, then our hands are kind of tied, unfortunately.
And I think it was a slide that you showed that I think it was like $75 or $80 a month for the vitamins or something that the person would have to take.
Mm-hmm.
So is that insurance covered, or is that?
Sometimes they will cover it if we prescribe the vitamins. Sometimes they will cover it. It depends on the insurance again, so it's variable because every insurance is different. But there's different costs depending on if you take an oral vitamin or if you take. There's patches now that people can wear patches and get their vitamins absorbed through the skin, but usually the patches are more expensive. So it kind of depends on which way you want to go. But the vitamins are important for the reasons we talked about. But yeah, it's something to factor into the decision-making process. You want to make sure that you're able to afford those because that's part of that lifelong management that I had talked about.
Anyone else? I'll take that as a no. Well, thanks, Dr. Snow. This has really been great, and we really appreciate you taking the time to do this talk and answer all the questions. Great questions. So thanks everyone for asking questions and attending tonight. So thanks so much.
Well, thank you for the opportunity. If there's anything you need on the back end from me, I'd be happy to help out or distribute any additional information. But I hope you all have a good evening, and thanks for listening to me talk.
Yeah, thank you. Very informative. Thank you.
Thank you.
Bye, guys. Have a good evening.
Bye-bye.
Thank you.
Ladies, tomorrow is Fresh Pharmacy, as a reminder. I'll send an email to you.
Okay, thanks.
Okay, thank you.
Y'all take care.
Okay,
bye-bye.
I may be calling him for an appointment. No, I'm just I'm gonna have to think about it a little bit longer.
I'd like to see if I could get a redone.
Well, you probably could. You should have asked him, you know, what are the, you know, risk or, you know, probably, I mean, I guess to get the approval from insurance, you would have to have, you know, some medical issues for your insurance to cover it. That's the only thing, you know, the insurance companies are resistant.
Yeah.
You know, that's the issue, you know, they make it difficult sometimes.
Yeah, by me not working there, I probably wouldn't qualify now. So I just have to start walking and running more.
Yeah. I mean, on the one hand, it sounds good. I mean, you know, as far as for the risks, you know, because as we get older and being obese, you know, you're just putting yourself at risk for more problems. But, you know, it's like, then you look at having the surgery. And I mean, it does seem like most of the surgeries are, you know, they've come a long way with the research and everything. And I wasn't aware that they had this many different types of procedures that they
Me
could do.
either. I didn't know it had all of this now. They have really come a long way.
Yeah, they have. And I mean, you know, the original bypass procedures that a lot of people got years ago, and before they knew all this, you know, they weren't as successful and people had a lot of problems, and you know, the mortality rates were higher and all of that. But yeah, it's good to know that there are options, you know.
When I got mine, they opened me up completely from the top down to my belly button.
Yeah, well, you probably yours was a complete bypass surgery?
Yeah, I had the gastric bypass. Yeah, but they opened me up completely to do mine. Yeah, and then now they just do the little holes, you know. So
everything now, you know, they're trying to do as many surgeries as they can laparoscopically, because having the big open incision puts you at a big risk for infection. Bleeding. And so if they can do it laparoscopically now, they recommend that more, because it's they call it less invasive, meaning not opening the person wide open, which puts them more at risk for the infection, which that's a big problem, you know, if you get infection from those surgeries. So yeah. I mean, there are a lot of factors to consider.
It is.
But,
I was just very fortunate, you know.
Yeah.
So.
Yeah.
All right. Well, thank you.
Okay. Well, you take care. Have a good rest of your evening.
All right. You too.
All righty. Bye-bye.
Bye-bye.
I forgot to stop the recording.